We're going to be talking to Dr. Nafysa Parpia. She is a board-certified naturopathic doctor and has spent the last decade treating patients with complex chronic illnesses. Dr. Parpia is a sought-after speaker at medical conferences and summits. She is on ISEIA's Board of Directors, which is the International Society of Environmentally Acquired Illness, and is a scientific and medical advisor for Neurohacker Collective. Welcome, Nafysa. So glad to have you today. We're going to be talking about the relationship between the thyroid gland autoimmunity and COVID-19. Tell us a little bit more about your practice and what you do.
First of all, thank you for having me here. And I think it's super important information and you're getting it out there. So thank you for doing that. So a little bit about my practice. I focus on patients who have complex chronic illness. So meaning they have issues of inflammation and immune dysregulation that have been caused by a combination of infections and environmental toxins. So patients come from all over the country, even other parts of the world, to the clinic.
So important. Yeah, the work you do is amazing.
Thank you. Thank you.
So I'm really excited to talk to you about thyroid disease and COVID. And, it seems to be, the question is, can thyroid disease be a comorbidity for COVID? Or, is thyroid disease exacerbated by COVID? So can you tell us a little bit about how they play off of each other?
Yeah, so there's been some studies that show the patients with controlled hypothyroidism and hyperthyroidism do not have a higher prevalence of COVID-19, and they don't have worse prognoses either when they're infected with the virus. But the key word here is controlled thyroid diseases. And that's what most of the studies have been on, actually. So thyroid hormones have a role in immune function. So if your thyroid hormones are normal, you should be fine, whether that's controlled with thyroid medication or if you're just lucky enough that they're normal. So it's plausible that patients with uncontrolled thyroid dysfunction could be at a higher risk for complications. But there's been contrasting results regarding the immune functions in general. So then it's been difficult in the research for them to show if it's about more hypothyroidism or more hyperthyroidism. It does seem to be more related to hypothyroidism and Hashimoto's.
And that would make sense coming from the autoimmunity standpoint. And the other issue is a lot of people don't know that they have uncontrolled Hashimoto's, because if they're only checking a TSH, literally happened today. I had a patient, her thyroid was checked and she got a little note back from her practitioner saying, everything looks fine. And her TSH was 4.4. And I'm like, that is not fine. So we're digging into it more, but that could be another problem, right? Someone could not know that they have thyroid problems or that it's out of control. And then that could technically be a comorbidity for COVID.
Right. And that happens every day. So in my practice, people come in and they have these mystery symptoms, these mystery illnesses. They don't know why. They have no idea what's going on. They've been to lots of other doctors. They get a wastebasket diagnosis like fibromyalgia or chronic fatigue syndrome or long haul syndrome or autoimmune conditions, even like Hashimoto's. Well, what's that? What's underneath that? They don't know. And so it's our job to really uncover that and do full thyroid studies and all kinds of other tests to understand what's actually going on. But as far as the impacts of COVID and the thyroid, there needs to be a lot more research on this regarding the mechanistic actions. There's just so much that we don't know yet. Like we were just talking about, people weren't testing their thyroid necessarily fully. Usually it's not tested fully by most doctors. So
right. Right. And COVID's so new. I mean, it really is. And when we look at a disease that is practically brand new, we're all still understanding it. And I think it really took a lot of doctors by surprise, not so much functional doctors, integrative doctors, naturopaths. We kind of understand disease processes and why things happen the way they do and immune dysregulation. So, I think we were all a little bit more prepared for this and better at helping our patients. So when we look at COVID, do you think that, or have the studies shown that COVID can actually cause thyroid disease?
So it's been reported in the studies that abnormal thyroid function can be related to acute SARS-CoV-2 and also in long haul. The studies aren't clear as to how yet. There are some hypotheses, which I want to get into. And then there's also some ideas that I have about it as well. So although the cellular and molecular mechanisms are not completely understood, there are some ideas. So of course, there's the evidence of the cytokine storm, right? And that's known that that's an important mediator. So if it happens to attack your thyroid, you can develop hypothyroidism typically, or Hashimoto's. So there needs to be more studies though. The other thing is, right, despite being considered a respiratory disease, other organs and systems can be affected by the virus, including the thyroid. So we do know this, the thyroid gland as well, the hypothalamus and the pituitary, for those of you in the audience who might not know what they are, those regulate the function of most of our hormones. They all express angiotensin converting enzyme 2, or ACE2 for short, and that's the main protein that functions as a receptor to which the virus binds to enter the host cells. So then the spike protein of the virus interacts with ACE2 with very high specificity and affinity through the whole thyroid axis. And then also the immune system cells are targets for thyroid hormones. So T3 and T4 modulate specific immune responses, including natural NK cell activity, antiviral action of interferon, and the procreation of T and B cell lymphocytes. So that's what is known so far.
Yeah, it's really interesting because when we look at viruses interacting with thyroid, it's not necessarily a new concept. There is this subacute thyroiditis situation that you can get, and it's usually caused by different viruses, and the thyroid swells up. You get really hyperactive, and then you need to treat that with steroids, or what I saw one case of subacute thyroiditis. It was actually missed in the ER. The patient came to see me, and she didn't want to go on steroids. She wanted more natural. So I put her on low dose naltrexone, and I used ivermectin because she was still having COVID symptoms, because it was right during COVID, and it calmed her down. And her numbers got better. But really, subacute thyroiditis, something's wrong. She had anterior neck pain. She had back cramps because she was losing so much weight because she was so hyper, but no one had checked a free T4 or free T3. They just had checked a TSH. So this is why listening to these talks are helpful, because maybe you or a loved one, they go through something like this, and you could be like, wait, I listened to that talk and we should dig further. But yeah, the subacute thyroiditis is very interesting with regards to viruses and COVIDs, and especially some of the studies out that saying that they do see this transient hyperthyroidism post-COVID if you would check thyroid labs. But there isn't a lot of research, because not everyone going into the hospital, they're not checking these thyroid labs routinely on these patients. They're checking a lot of other markers, but the poor thyroid gets neglected, right?
Right. I mean, it happens every day. We see it every day with our patients. It's just so common. But so I want to talk about long COVID and
Yes,
how
yeah,
viruses and other infections, right? And about how it can cause, how long COVID itself can cause what is in remission in our patients to now come to the surface. So what I want to do is take this back to what causes Hashimoto's in the first place. And I want to look at this from an infectious point of view, actually. So this is because COVID-19 has some things in common with all other infections. They all cause an inflammatory cytokine flare. What it doesn't have in common with most of the other infections is the spike protein. But now we know that the virus infects the cells of the thyroid gland via the ACE2 receptor and the spike protein affinity to them. We know that patients who suffer from long haul COVID syndrome, typically they have the awakening of dormant infections there in their immune system that they could previously keep in check. That's in the research. So the inflammatory cytokine flare from the spike protein or from other proteins in the virus can directly affect the thyroid gland, the hypothalamus, and the pituitary, That's in the research. And it can also cause dormant infections to flare. Again, in the research. What's not in the research is how it can lead to Hashimoto's. But this is where I have some ideas, and I want to take this backwards actually to the root cause of Hashimoto's, because it's those that first get flared in the long haul. And this is where the two intersect. So then there could be other infections. Chronic infections are found in people with Hashimoto's in the first place. Infections like Lyme, Epstein-Barr virus, cytomegalovirus, parasites. There's papers on that, right? Including Lyme and Epstein-Barr virus, H. pylori, Yersinia. And so, well, COVID-19 infection comes and it goes, but it leaves behind a trail of inflammatory cytokines throughout the body. And that's what wakes up these dormant infections. That's what also causes the thyroid to flare. So now we've got these active infections causing further inflammation. So now in these with long haul COVID, we've got pandemonium in the immune system causing inflammation that contributes to Hashimoto's or other autoimmune conditions, but that depends on the genetic tendencies. So we're talking about inflammation meets the genes here.
Yeah, and it's really scary because this one virus, I mean, COVID and the spike protein, it has really left some collateral damage. And this is why I really think with COVID, early treatment is very important, because the earlier you get this virus under control, the less spike protein, the less cytokine storm. Okay. So, I talk about it like we have hurricane, right? You want to keep it a tropical storm. You don't want it to be, a class 3 hurricane and all that wreckage after. Because like you said, it kind of wakes everything up. And I've said it just brings out medical problems that people might not have realized were there, or the body was keeping it in check. Like, it can really be problematic. And I think that people don't have a lot of places to go because this is not well understood like it is understood with, doctors like you.
Right. And then there's the emotional stress of the pandemic, right? So there's this global trauma that we've been in, and sometimes that gets ignored. I'd say gets ignored publicly, and people have been facing it day to day in their lives, but there's also this connection between stress and Hashimoto's, or stress and autoimmunity in general. So now we add on inflammation caused by dormant infections that have been woken up, inflammation caused by spike protein itself or other parts of the virus, and now we add trauma on top of it. And so we have this perfect storm for long haul syndrome, not just Hashimoto. So Hashimoto's is just one slice of the pie of long haul syndrome. So I see this every day in my patients. Almost anybody who walks in, actually, everybody has complex chronic illness in my patients. But now I'm looking at it through the lens of spike protein, or through the lens of higher inflammation than there was pre-pandemic, because this changes the entire landscape, right? And then adding on the stress piece. So we have to do a lot of emotional work with people as well, working on their nervous systems. So it's a multi-pronged approach of how to address each person personally.
Yeah, I love that you brought up the emotional component, because a lot of people can ignore that. And that is part of the pie. That's part of the puzzle. And if you leave that out, then you're doing, a disservice. And unfortunately, I think we all have a little bit of trauma from the pandemic, right? I mean, we were all super scared. I remember I couldn't find an N95 mask to wear in my shift in the emergency rooms. I was working quite a bit of shifts during the pandemic. I was trying to buy ponchos in case I had to intubate someone to keep my staff safe, to cover everything so the respiratory aerosols wouldn't spray. It was crazy. It was a crazy time. I mean, I think when we look back at that, we all kind of have trauma, and that trauma is definitely, we don't want that setting up shop in our body. We need to deal with that, because that is one of the factors that can lead to autoimmunity and gut disruption and all of the cascades that go with an autoimmune disease, and Hashimoto's and thyroiditis. So what are you seeing in terms of patients coming into your office with COVID and long haul, as it relates to these thyroid and autoimmune diseases?
Yeah. So there were patients that I had for, prior to the pandemic, obviously. These patients, like I said before, they have a combination of infections and toxins causing secondary immune issues, which then cause inflammation and secondary illnesses on their own. I want to explain this a little bit more. I tell my patients there's 5 underlying reasons that make you sick. Infections. Okay, those infections can be viruses. Now this new one, not so new anymore, right? Parasites, mold, other bacteria. These infections can be throughout the body. They can be in the sinuses, in the gut. They can be systemic, really. So infections, toxins, so environmental toxins. I'm thinking of glyphosate, heavy metals like mercury, lead, arsenic, aluminum. I'm testing for those. Pesticides, solvents. So infections, toxins, stress, which now we know we have more of, diet, the standard American diet, and structural integrity issues. So all of my patients have some level of all 5 of these issues going on all at once, or else they wouldn't be my patients. That's why they're all so complex. Now, somebody who might have just one of these things, maybe a poor diet, or maybe just a structural integrity issue problem, they wouldn't be my patient. They could deal with it. It's more simple, right? So they have all of these going on at once, flaring. And then what I say is, now look at this hand. Okay, this over here is all of these triggering inflammation and immune dysregulation. So when I'm talking about immune dysregulation, I'm talking about a hyperactive immune system and a weak immune system simultaneously. So when it's a hyperactive immune system, that's when we see autoimmune conditions like Hashimoto's or rheumatoid arthritis. We're also seeing mast cell activation syndrome. That's another vantage point of a hyperactive immune system. At the same time, these patients can't mount an appropriate immune response to kill infections that they should be able to. So then, because of that, they've got these other diseases, long haul syndrome, fibromyalgia, all these wastebasket terms that these are really terms that the doctors give to people when they don't know what's going on. So we're going to give you this label because we don't know what's going on. So I go back and I diagnose these things, and I'm treating all of these things. So that now, think about these patients who get COVID or they get a vaccine. At first, they were afraid. They were so afraid to get COVID. They were so afraid to get the vaccine. And when they did, most of my patients did just fine. Why? Because I was treating all these 5 things. I was pressing on their infections, treating them, detoxifying them, modulating their immune system, typically with peptides, doing all of this stuff, right, to deal with these reasons, these triggers, while I'm also dealing with immune dysregulation and inflammation simultaneously. So that along comes COVID, and my patients are doing just great. Most of them are on low dose naltrexone anyways, because they already have autoimmune conditions. So these patients did fantastic. Most of them actually did fine with the vaccine, and they did fine with COVID. So at first we were kind of surprised, like, we thought these ones would have the hardest time, but they didn't. They did just fantastically. Everything was being treated that would be a cofactor to cause long haul syndrome. And then there are people, go ahead.
Yeah, because you're having their inflammation down and you worked on their gut health, and I'm sure they had optimal vitamin D levels and everything. So definitely that makes a lot of sense.
Yeah. And then people with long haul were coming into our clinic in droves right after they had COVID. Some of them were vaccine injured. We were part of Dr. Bruce Patterson's long COVID group. Our clinic was. And so at first, we followed his protocol, and sometimes it worked, sometimes it didn't. So for those patients who Maybe it was just their vitamin D, or maybe it was just something minor. Maybe their thyroid was a little bit out of balance, but they didn't have many other infections. Maybe they just had a very, very low grade of inflammation to begin with. We gave them a basic protocol and they did fine. Other people, they didn't do fine. The basic general protocol, some low dose naltrexone, some vitamin D, some melatonin, right? Didn't work. So that's when we realized we've got to start treating these patients like there are typical complex chronic patient illnesses, because what we're seeing here is this cross section between chronic Lyme or chronic infections, chronic post-infectious disease, along with long haul COVID. So then I had to uncover what else is underneath these patients, just like I would with any other complex chronic illness patient. And of course, I found other infections that the patients had no idea they already had. Lyme disease, tick-borne disease, it's a big one that people with COVID, long haul COVID had. Epstein-Barr virus, Mycoplasma pneumoniae, chlamydia pneumoniae, other viruses, right? A lot of them in the herpes family. And of course, a lot of environmental toxins. But before they got COVID, these were not giving our patients much of an issue. Maybe the patients had a little bit of a sleep disturbance, or a little bit of PMS, or maybe a little bit of pain or stiffness when they wake up in the morning, but nothing to turn their life upside down until the inflammatory cytokine storm came, until spike protein came, and then those infections flared, and what didn't matter suddenly mattered, and their life was turned upside down. I want to bring it back to Hashimoto's, because inevitably, many, many people who have long COVID in my practice do have Hashimoto's as well, for the very reasons we've been talking about.
Yeah. And when you have COVID coming in there and wreaking havoc, it does bring, you got to think about it is we live with viruses and bacteria in us. You know, we're made of them, they're there, we coexist. So the problem is when your bucket kind of overflows, whether it's with environmental toxins, emotional trauma, viruses, the spike protein, and then your body's just like, whoa, wait, I'm done. I can't handle this anymore. And those diseases flare. And I explain that a lot to my patients that, you know, they're like, could I have Lyme? And I'm like, yeah, you could, but first we're going to focus on getting your body healthy, getting it into homeostasis, you know, unless it's an acute Lyme issue. You know, I don't just go and, you know, bomb the Lyme with, you know, antibiotics and stuff when they're not doing well. So I think that people do have to realize is that you could definitely have all these underlying viruses in there. I mean, so many of us had, you know, Epstein-Barr or mono, you know, the kissing disease in high school. And, you know, some people end up with chronic Epstein-Barr, and it's for the reasons that we've been talking about. They have other issues going on, and those issues have gotten out of hand. And
Right.
And some people live with it. You know, it doesn't reactivate ever. So I think that, you know, definitely like COVID, yes, it was scary. It kind of shocked everyone, but more so that this virus in particular is wreaking so much havoc long term is just very interesting.
And you touched upon a point that was really, really important, actually, and it's about timing, right? When do you come in and treat Lyme? Timing is crucial here in complex chronic illnesses. And when we have these infections, that when the patient already has immune dysregulation going on, we know they do. We test it on the labs. It's obvious, right? They've got autoimmune conditions. They've got mast cell activation syndrome. They're hypersensitive. Now, anytime we kill infections, there's a release of toxins. There's a release of biotoxins, toxins from dying cells, dying infections. And I tell my patients, they want to kill the Lyme right away. If we do that, we're just going to release more inflammatory cytokines. We're going to release biotoxins. You're already up to here with toxins. So that's going to result in you feeling worse. It's going to result in further inflammation. A lot of patients even say, but isn't it a good thing if I feel bad? Like if we start to kill the bugs and I feel bad, doesn't that mean it's working? Right? Well, no, we don't want to work like that, right? Because now you're more inflamed, and it's actually absolutely not what we want to do. So I'm working with modulating the immune system first. Now, usually I'm modulating the immune system with peptide therapies, because before the advent of peptides, I wanted to modulate the immune system first. I couldn't find anything that could do it as well as the peptide. So typically I'm doing that first, and then I'm bringing in detoxification therapies as that's pertinent to the patient. So taking a clear history on what's going on with them environmentally and testing it on the labs, and then starting to slowly bring in the detox, looking at patients' genes, their genes of detoxification, their genes of inflammation, the genes of their brain chemistry, the whole thing. Because when we marry that with what we see on the labs, we get a lot more information. So doing all that, those preliminary steps, preparing the patient for detox, actually. And I've got an ebook on pre-tox, which is about detox preparation. And then finally, guess what? When it's time to kill the Lyme, very often the Lyme is taking care of itself. We don't even have to. And when I'm talking about Lyme, I'm talking about all tick-borne diseases: Lyme, Bartonella, Babesia, Ehrlichia, tick-borne relapsing fever. And rarely have I seen Lyme without mold. Typically they go hand in hand. So typically I'm treating mold even before I'm treating Lyme. So it's this dance, and the patient is on a journey, and it's an individual journey for each person. And then to bring it back to Hashimoto's, like I said before, it's one small slice of the pie with respect to this, but it's a really important one. And the thyroid is like the canary in the coal mine. It's usually the first one to raise its hand and say, hey, there's something going on here. There's inflammation in my system. So very often we'll see autoimmune conditions, other autoimmune conditions, maybe in the connective tissues or RA, but it's usually Hashimoto's that comes first, and then the rest follow. But we have to deal with them in the ways that we've been talking about.
I love that you said that about the thyroid, because I was thinking that when you said that the thyroid's the first, and it is. So sometimes your thyroid markers might be a little bit off. So then, your integrative or functional practitioner is like, okay, we're going to do a full panel. And then you'll see the thyroid antibodies being mildly elevated. And you're like, okay, let's go. This means your gut is out of balance. We got to investigate more. Something's going on. You have this autoimmunity. So when people are, diagnosed with a thyroid problem or Hashimoto's, you have to look at the big picture. Why is this happening? What's going on? What do we have to fix in the gut? As I tell my patients, as Hippocrates says, all disease begins in the gut. So I narrow down and I go there, and that's where our immune system is. So yes, the thyroid can be kind of like you said, a canary in the coal mine, a warning sign to maybe something bigger going on. And a lot of people want to jump to the Lyme and all of that. And it's like, whoa, let's fix the gut. Like you said, if there's mold, that has got to go. It's very immunosuppressant. So that is going to mess with your immune system. So I would love to have you talk about peptides. If you could touch about those for a minute, because I love peptides and I like to geek out on them. So what are your favorite peptides that you were talking about that you use in these conditions?
Absolutely. So usually I'm wanting to modulate people's immune system first, like I said. So most of my patients have mast cell activation syndrome. So I'm using KPV and Amlexinox to modulate mast cells. I'm usually bringing ketotifen on board. Of course, it's not a peptide, but it helps a lot with mast cell activation syndrome, low dose naltrexone. And I'm also using BPC 157, good old BPC. It's like it's my favorite peptide. It brings inflammation down in the gut and everywhere. Or if you inject it in areas of pain, it brings pain down. A lot of my patients have cranial cervical instability, whether it's mild, moderate, or severe. BPC 157 cream applied to the back of the neck can really help with that, or BPC 157 injected just subcutaneously or in the muscles intramuscularly can really help a lot with pain. And what else do I love for peptides? TB4 frag. So usually I'm using the peptides to calm down the immune system first, and then I might start to use other ones to start to kill infections when the time is right. Thymosin alpha is a good one, LL37, those are my go-tos for when the time is right. For sleep, our patients have a lot of sleep issues. I like to use a combination of delta sleep inducing peptide and epithalon along with thymosin. That trio really helps people with sleep. A lot of times our patients, they're not able to have intimacy with their partners because they're so sick. PT141 helps a lot with that. You can give them a little bit of kisspeptin, a little bit of oxytocin with that. That's going to help with their sex lives, which is so important to them. And then for the neurotropics, I like to use Cmax and Clank. So Cmax is going to help with brain inflammation. So will RG3. That's not it's not a peptide, but it works a lot like one. And then Clank to help with memory. But what I've noticed with the neurotropics is that the inhaled ones, right? They're not going to work very well when the patient has infections in the sinuses. So usually I'm dealing with those infections first, and then I'll give them the inhaled peptides. And that's when I start to see them working. So often I see infections in people's sinuses. I mean, every day I'm seeing that, not only just Marcons, which is a kind of staph infection, which is common in people who have Lyme and mold issues, but I'm also seeing funguses, all kinds of funky bacteria since this pandemic, lots of biofilms. I'm wanting to treat that before I give the inhaled neurotropics. So
yes, that's great. I love peptides, and it's kind of new to a lot of people. And how I explain peptides, they're chains of amino acids, and insulin is the most famous peptide. So insulin, which diabetics inject and which our pancreas makes. So peptides, they go to where they need to go, and they work how they want to work, how they are supposed to work synergistically with the body. They're not a drug. Okay. They're not just like gonna go in and do whatever they want and wreak havoc. They work synergistically, and it's a whole nother world, and it's a great world to use when it's necessary. And like you said, some like LL37, very strong antimicrobial, it's antiviral. Some studies are showing that they're using in different studies to get to heal things from an antimicrobial standpoint. And that will, yeah.
of the bacteria and the viruses. So that helps to kill them. Yeah.
Yeah, the LL37, I don't use it a lot. I kind of use it after I've tried some other things because it is so strong. Are you seeing good results with it with long haul, or what specific infection are you using that one a lot for?
Because it perforates the cell walls of multiple viruses and bacteria. It's one that I definitely use. It's not my first line because, like I said before, like we were talking about, if we start to kill infections first, we just get a flare of inflammation. So when it's time to start killing the infections, and that's different for each person, it has to be really personalized, I will bring it on board along with the TA1, but I'm also going to keep the ones that are calming the immune system down as well, because I don't want to kick up an immune response. Here's the thing: if somebody has an autoimmune condition and I give them things, or anybody gives them something to stimulate the immune system, we can stimulate an autoimmune condition. So we have to be really careful about what we're giving to people, when we're giving it to people. So depending, but when the time is right in the right patient, yes.
Yeah, absolutely. And you brought up two of my favorite that I really like. I use a lot of them in combination, the KVP and BPC 157. So very, very good. The KVP is great for inflammation, and BPC 157 is just amazing in general. And you make it in your body, in your gastric cells. So, but anyway, I love that you brought up peptides because they are such a good tool. And that's the thing. You and I have a lot of extra tools in our toolbox, because when you see patients with chronic complex illnesses, the same tool does not work for every person, So I think it's great that, like you've said, that you have all these different tools. So do you have any other patients that you would like to tell us a story about that would help people understand what you do a little bit better?
Yeah. So let me think. So here's a patient from, he came from the East Coast, very, very strong, robust patient before I met him. Came and I didn't know why he was exhausted, didn't know why he had brain fog, didn't know why he couldn't be an athlete anymore. Why are his muscles not the way they were before? Why can't he lift? Why can't he run? What's going on? Didn't have a diagnosis, actually, went to many, many doctors. There wasn't one. And so I did my usual thing, right? Testing for infections, testing for toxins before doing a thorough clinical intake. So when I'm asking the patient very, very directive questions, I'm getting their history, and each patient has a key. What is it that's making you sick, right? So I'm searching for that key, and so when I say I'm testing for infections and toxins, it's not so simple. I'm really talking to the patient to understand what infections I want to test for, what toxins I want to test for. So of course, I'm always doing basic blood work as well, which I'll consider a full thyroid panel also, and concurrent infections to Lyme, which would be things like Epstein-Barr virus, cytomegalovirus, HHV6, HHV7, mycoplasma pneumoniae, chlamydia pneumoniae, those viruses and bacteria I see all the time. Mold IgG allergens, very common. If the mold IgG allergens are high, then I'm going to start looking for mycotoxins. I'm going to find out more about mold. Testing for environmental toxins if that's indicated. In most people it is, because we're living on this toxic planet. So tested for all the things that were pertinent to him, found tick-borne disease and high glyphosate, high metals. So he came to the clinic and had, in his case, the Lyme was neurological Lyme. So he needed IV antibiotics. That's not my go-to. People get them at our clinic, but when we do that, we're detoxifying them same day. So there are other clinics that a patient might go to and get IV antibiotics, but then they just go home and all hell breaks loose. So when we're doing IV antibiotics, it's got to be managed with detox and immune modulation. So did that for him. So maybe he got PK protocol IVs after, or maybe he got some vitamin C IVs and ozone, and other detox formulas as well. So doing that in conjunction with infection killing and the peptides, and within 6 months, he recovered. But that was coming to the clinic and really working hard, both of us working hard, my patient working hard, me working hard, following the patient, watching them like a hawk, right? And then because the treatments are given every day, the patient is a moving target. So watching them move every day and adjusting their treatment to that. So it's that kind of attention that needs to be given to a patient when they're that sick, when they've got that much going on that's mysterious. And then typically they return home and they're great. Other patients, if they don't live in California until they can come to California, I will give them supplements, but they need to have a doctor in their state who will prescribe medications, because my license is in California. So I can't prescribe for you from other states, but I can consult with you, which I do all the time as well. And so this patient, like many of our patients, came, did intensive therapies, went back home happy, free. And that just brings me so much joy to see that. It's the peptides that make that go faster.
Yeah,
That's
a great story.
Yeah.
Yeah. And like you said, sometimes these chronic illnesses and even the thyroid and Hashimoto's, it does take hard work, and I don't think that there's anyone that has come to my office and just not put some work in from a dietary standpoint, or, maybe meditating or starting to move their body. You have to be a team player and continue these healthy daily habits. It's not just a pill and they're better, or even just a peptide and they're better. They still have to get good sleep and have good habits. So
If
I
they're
think that's a
not,
great story.
if they're not getting good sleep, healing is going to be very difficult. So we have to work on those things. I call them the baselines of health: sleep, diet, movement that's appropriate for the person. Some people want to, push themselves, and when they suffer from long haul syndrome or chronic fatigue syndrome, pushing themselves doesn't work. One of the hallmarks of ME/CFS is that you exercise, you do some movement, and you get worse. And so if that's happening, then definitely don't push yourself. So do what you can do. But I tell them that those therapies, just simple ones, diet, lifestyle, movement as appropriate, those are like the foundation of the house. And then if you want to come to me for those cool therapies, of course, right? That's what's going to make everything else. That's what's going to treat the infections, treat the immune system. But without the foundation of the house first, all those therapies are just going to fall through the cracks. In emotional work, I can't stress that enough, because most of my patients have had some kind of trauma in their lives. Now everybody has, like we were talking about before, in this pandemic, but a lot of people have had trauma from other things, and that's a contributor to immune dysregulation, the stress that goes with it.
Yes, it is. Well, thank you so much for sharing your knowledge with us. Nafysa, you've been amazing to talk to. How can our listeners find you, get in contact with you, all of that?
Thank you. So they can find me at Gordon Medical. We're in the San Francisco Bay Area. It's just gordonmedical.com. Thank you so much for having me.
Thank you so much. It was such a great talk.
Thank you.